panelist from the California Medical Association is David Ford, their Vice President of Health Information Technology. Mr. Ford.
All right. Thank you, Dr. Wood, members of the committee. Thank you for having me today. And more importantly, thank you for giving me the first reason I've had in more than a year to put on a tie. As I considered the questions that your staff asked us to address, I decided the best place I could start is here. It's important to understand that health information exchange is not a noun, it's a verb. HIE is the action that physicians, provider organizations, health plans, and others engage in when they transfer patient data. What we traditionally refer to as an HIE is more properly called an HIO, a health information organization. And an HIO is only one method that physicians and other providers use to engage in HIE. There are also the national networks such as CareEquality and Commonwealth. And then with the coming of the coming implementation of the federal information blocking rule and the patient access rule, we're going to see the rise of patient-driven app-based data exchange. And it's important to consider all this context as we approach setting HIE policy for the state. We unfortunately often accept as truth that providers don't do HIE. Well, what we mean is that they may not participate in an HIO, but they may be exchanging a whole lot of data using other methods. And any solution we would build to the state has to be inclusive of all of these technologies, as well as the new ones that are coming online. Now, it's also true, however, that the rollout of HIE in the state has been very uneven. As the previous speaker spoke so eloquently to, many smaller, underserved, and/or rural providers have been left out. This is either because they don't have access to the higher functioning EHRs, which allow them to get onto the national networks, they lack the resources and support to connect to an HIO, or they don't have access to broadband internet that can support exchange. About 3 years ago, CMA and a large coalition of others worked with the legislature to build a $50 million program, $45 million of which was federal, known as CalHOP, the California HIE Onboarding Program, that was supposed to help resolve this issue and help bring the smaller providers into the fold. Unfortunately, 3 years later, that program has only spent a fraction of its allotment and is almost out of time. The other essential piece of this context of this discussion, which I mentioned very briefly, and as did the previous speaker, is the twin federal regulations set to take effect this year: the information blocking rule, which comes in April, and the patient access rule, which comes in July. Taken together, these two rules mark a shift in direction in the world of HIE. Once they are fully implemented, all actors in the healthcare system, so that's physicians, health plans, hospitals, and others, are going to be subject to federal civil monetary penalties if they attempt to impede the flow of patient data. So anything we do in California has to have all of that as a backdrop. With all that in mind, and to address the questions raised by the committee, CMA believes the state of California should do 4 major things. And first, and this has been mentioned several times, is unlock data sources that are held within the state of California. Committee staff had asked a question about how the state could leverage data exchange to address the current public health emergency as well as future public health emergencies. And really the most important thing we can do in that regard is to make the data that's currently held in CalReady, in the immunization registry, and I would like to add the Cures database, and other similar sources accessible at the point of care. This would help treating physicians to know when one of their patients, for example, has tested positive for a reportable disease, or as we're dealing with right now, when they've received a vaccine. The second thing that we need to do is to provide support to small, underserved, and rural practices. The committee had asked a question about how HIE could be used to address the important work of addressing health inequalities, which is an important topic. It's a very important thing for CMA. And the biggest thing we can do to start off with is we need to make sure that data is flowing both to and from the places where underserved patients are receiving care. Largely, those are going to be small practices, community health centers, rural providers, and we need to make sure that, as I've mentioned several times now, we need to bring all of those folks into the fold of health information exchange. Third, reestablish the state's role as the facilitator of health information exchange. I had a lot more to say on this, but Jonah Froelich, the first person who held the position of Deputy Secretary of Health Information Technology, obviously could speak to it much better than I could. But the point is there used to be an HIE infrastructure. There was a stakeholder process within the HHS agency. Over time, that infrastructure atrophied and then dissolved. It was not considered a priority. And what happened was when opportunities like CalHOP were delayed or faced difficulties, it was really unclear who was in charge, who stakeholders like us could go to talk about what was going on and how to fix it. So it's time to start bringing back that infrastructure. And finally, as we start talking about what I consider sort of the non-traditional sources of data, social determinants, behavioral health, as you know, we really do need to be looking at all of the available federal funding opportunities. The CHCF reports that we're giving to the committee provide several excellent possibilities. It included what's called MITA, Medicaid Information Technology Architecture, which is a line of federal funding that provides a 90% federal match for build out and 75% federal match for maintenance. There's rural broadband funding at the FCC, which could help fill in a lot of the gaps in our internet infrastructure. And I'll just tack on one that hasn't been mentioned that possibly doesn't get enough attention, which is Section 6001 of the Federal Support Act, which actually opens up the possibility of creating a meaningful use type program for behavioral health. We should be looking at that as well. But really, as you know, all of these federal dollars can help us fill in the gaps in the system, bring non-traditional providers, and I only mean that non-traditional in that they have not traditionally participated in health information exchange, but bring them into the network and get them exchanging data. So with that, Mr. Chairman, thank you for your time, and I'll be happy to hang around for questions.
Great, thank you very much. So we have next from the California Pan-Ethnic Health Network, Carrie Sanders, a senior